biomedical webinar titled Delivering Effective High-Frequency Oscillatory Ventilation in the Neonatal Intensive Care Unit. We're delighted to have you join us today. We are honoured to be joined by Professor Anton van Kaam, Professor of Neonatology and the Chief of the Neonatal Intensive Care Units at Emma Children's Hospital in Amsterdam Medical University Centers in Amsterdam. Following the presentation, we will have some opportunity for some Q&A. If you have any questions throughout the webinar or at the end, please feel free to pop them in the Q&A box and we'll address these at the end. Without further ado, I'd like to hand over to Professor van Kaam. Thank you.
Thank you very much, Chloe, and thanks for the invitation to talk about high-frequency ventilation. Before doing so, these are my disclosures. So today we're going to talk about high-frequency ventilation, and I think it's important to always ask yourself the question, is the talk still relevant? Because as you all know, we are increasingly managing our preterm babies on nasal CPAP from birth, and this is already some older data from the Vermont-Oxford network, showing you over the different years how many of the babies below 1,500 grams were actually managed on CPAP. And you can see there is indeed a steady increase in the number of babies that are managed on CPAP. But if you look at the number of babies that are actually still ventilated at some point in time during their admission, you can see there is a slight decline, but roughly 60 to 70% of the preterm babies below 1,500 grams still get on a ventilator. So I think it's important to realize that we need to talk about lung protective ventilation, and in this case, high-frequency ventilation. Because we also know that BPD is one of the most common complications of preterm birth. And we know that bronchopulmonary dysplasia is a multifactorial disease, but we also know that ventilation and lung injury is still an important risk factor in the development of BPD. And this was nicely shown by this study done by the Italian network, where they looked at preterm babies, what were the risk factors for babies developing BPD? And as we expected, ventilation was one of the key risk factors for developing BPD. What to me is really interesting from this study is that they also looked at the duration of mechanical ventilation. And as you can see here, if babies were ventilated less than a day, they actually did not have an increased risk in terms of the odds ratios. But as soon as you cross the day up to 7 days, you can already see almost a 2.5 increase odds in developing BPD, especially if you're on a ventilator for more than 7 days. This odds ratio rapidly increases. To me, it shows that mechanical ventilation for a couple of days is not an innocent treatment. It already increases the risk of BPD, and we need to be aware of this. So what is actually causing the lung injury that contributes to the development of BPD? Well, we know that volume entering the lung is traumatic to the lung, and this is called volutrauma. And this is shown here by these experiments in preterm lambs with RDS. And as you can see, if you have increasing tidal volumes from 5 to 20 mL per kilo, and you look at markers of lung injury, on the left side in yellow, the protein leakage in the alveolar space, and on the right side in blue, the compliance of the lung, you can see that the bigger the tidal volume, the more injury you get to the lung. What has not so much been appreciated by neonatologists at the start is that atelectasis is also a key risk factor for lung injury. Again, shown in these preterm lambs, where they ventilated the lambs with 0 positive and expiratory pressure, leading to a lot of atelectasis, or a PEEP of 4 centimeters of water. And again, looking at lung injury, protein leakage on the left, neutrophil influx on the right, you can see that if you increase PEEP, thereby reducing atelectasis, you will be lung protective in these animals when they're on conventional ventilation. There are some different mechanisms that actually lead to lung injury if you have atelectasis, but what's really important to remember is that atelectasis can lead to regional alveolar overdistension or regional volutrauma. And I've tried to illustrate this in this slide. On the left side, you can see the set tidal volume by you as a clinician. Now, you might think 6 mLs per kilo is indeed in the lung protective range of 4 to 7 mLs per kilo. As you set this at the Y-piece and there's no atelectasis, then the 6 mLs is evenly distributed across the lung. However, if you set this 6 mLs per kilo and half, so 50% of the lung is atelectatic, then this 6 ml is actually only reaching half of the lung, and at the regional level, the tidal volume will therefore be 12 mLs per kilo. And as you can imagine, this will lead to overdistension and lung injury. We also know that oxygen, high amounts of oxygen, are injurious to the lung, as shown in these studies in piglets, where you can see that if you have the combination with 100% FiO2, that the increase in lung injury expressed here as the albumin leakage in the alveolar lavage fluid is highest in those animals. So if we're not careful, we are going to end up in this circle where we have a patient that's failing on nasal CPAP and needs to be intubated because of respiratory failure. We start mechanical ventilation, we get ventilator-induced lung injury, resulting in edema, inflammation, and surfactant inhibition, and this will lead to a further deterioration of the lung function, and you need to increase your ventilator settings, and if you're not careful, you get stuck in this circle. So what you want to do if we ventilate our babies is we want to be as lung protective as possible. I'd like to note that no matter what you do, every time you intubate a baby and put a baby on a ventilator, you will get some degree of lung injury. So the best way to treat these babies is a non-invasive support, of course. If you start ventilating these babies and we know what's causing the lung injury, we can also define what should be our lung protective strategy. Well, if there's atelectasis present, we should first recruit the collapsed alveoli or saculi in the less mature babies. We then should stabilize the alveoli during both the in and expiration and prevent end inspiratory overdistension by using the slowest possible pressure amplitude in order to reduce the tidal volume and volutrauma. And of course, we have to reduce oxygen concentration and avoid hyperoxia as much as possible. All of these ingredients together is what we would call an optimal lung volume or an open lung ventilation strategy. Now, high frequency has been mostly associated as a lung protective modality. And why is this? Well, there's a basic difference if you compare high frequency to conventional ventilation. What you see here is that pressure trace over time. In yellow, I've depicted here the pressure trace during conventional ventilation, where we have a PEEP of 5 and a peak pressure of 25. And you can see we have this low frequency, high amplitude pressure changes over time. In contrast to high frequency ventilation, indicated here in white, where you have sort of a continuous descending pressure or mean area pressure, in this case 15, and on top of this, you have this high frequency oscillations with resulting in very small tidal volumes. And if you remember what I just mentioned about volutrauma and atelectatic trauma, these are actually zones you don't want to avoid getting into when ventilating your baby. You want to stay in the safe zone, avoiding these two injurious risk factors. And as you can see, with conventional ventilation, we are moving through these zones, resulting in lung injury. And hopefully by using high frequency ventilation, we can actually limit this injury by these very small pressure amplitudes. So this is the basic terminology, the principle that we use. Again, a mean area pressure, we like to call it a continuous descending pressure. And we have this pressure wave with an inspiratory phase and an expiratory phase in a very high frequency, usually to about 10 hertz or 600 per minute. And the difference between the peak and the troughs is what we call the delta pressure. Of course, we also set a bias flow and an FiO2. High frequency actually, when you try to manipulate oxygenation and ventilation, you actually can separate this pretty good, although it's maybe a bit simplistic to tell this in this way, but basically, if you want to target oxygenation, you should probably change either your mean area pressure or your FiO2. If you want to change ventilation, so CO2 clearance, this is mainly controlled by the amplitude, the inspiratory time, the frequency, and really important also the spontaneous effort of the baby, because the baby can still breathe during high frequency ventilation. And the fun thing is, there's no synchronization like with conventional ventilation. To me, high frequency is CPAP, endotracheal CPAP with a wiggle, and the baby can actually breathe without sinking to the high oscillatory amplitudes. There's one important difference that we need to be aware of, and that is there's a difference between conventional ventilation and high frequency ventilation when it comes to CO2 clearance. So basically what we know from conventional ventilation is that the minute volume is tidal volume times frequency, and this will give you CO2 clearance. So increasing either of these two will get more CO2 out of the baby, decreasing either one of these will actually get less CO2 out of the baby. But if the frequency crosses roughly about 5 Hertz, the definition of minute volume changes. Now it's tidal volume to the square times the frequency. This also is often referred to as the dCO2. And this means that by changing the frequency, we will also change the tidal volume in an opposite way. And because the tidal volume is to the square, this is the main determinant of what is happening to the CO2. What you need to remember is that if you apply high frequency, if you increase your frequency, you will get the opposite effect as with conventional, because it will give you less CO2 washout. If you decrease your frequency, you will get more CO2 clearance. This will change if you use volume guarantee, but I will go into that into more detail later on in my talk. So high frequency ventilators have been around for quite some time. And initially we had different types of what we call high frequency ventilators. One of the modalities that they used is high frequency flow interrupter, which is characterized by getting bursts of flow into the ventilatory circuit during inspiration, and then expiration was mostly passive, or sometimes supported by a Venturi effect. Then we have true oscillation, where there is both a movement of air during inspiration and expiration in an equal amplitude. And this is what we call active expiration, which is quite different from the flow interrupters. There are different ways to actually reach active expiration. You can use a piston or a membrane, or you can use, for instance, a negative pressure container, or a very high flow that is bidirectional. The key question has been, is there a difference, a clinical difference in terms of using active expiration or mainly passive expiration? And this was addressed in a couple of studies. This is a study by David Tink's group from Melbourne, Australia. It's a bench study with an artificial lung, where they looked at different high frequency ventilators, and they looked at the flow, the pressure flow trays during different frequencies in different ventilators. And they first looked at the left side in the airway opening. You can see that there is indeed a difference depending on the different ventilators that you use on the flow pattern. This is more square waved in the sensomatics and more sinusoidal waved in the, for instance, Fabian or Leonie. However, if you look at the tracheal level, there's actually not that much difference between these different ventilators. And this was also shown in an older study where they actually measured this in vivo in a piglet model where they looked at different oscillators and flow interrupters, and they measured the actual pressures that were delivered at the tracheal level. And you can see there is actually a benchmark difference in terms of the pressure waveform. Still, there are, if you look at very detailed to these pressure waveforms, small differences, but we don't actually know if there is a clinical relevance of these differences in our patients, and more studies are needed to actually tease this out. So, for me, the basic question that you need to ask yourself when you are starting to use high frequency oscillation, what is the primary reason? What is the underlying lung disease for which I'm using high frequency? And to me, there are actually two options. Either you have a recruitable lung disease, for instance, surfactant deficiency or surfactant inactivation, or a low lung volume because of abdominal distension, because of NEC, or you will have a high risk of overdistension or air leaks in a lung that is not characterized that much by atelectasis. For instance, a baby with prolonged rupture of membranes with lung hypoplasia, or infants with congenital diaphragmatic hernia. It is really important to ask this question because depending on the underlying lung disease, you will need a different strategy when using high frequency ventilation. So let's look at high frequency ventilation and the strategy that you should use in a recruitable lung disease. And this is the majority of the patients in your unit. So we know what is the strategy that we should use. We talked about this in the previous slides. The key question is, how can I monitor lung recruitment at the bedside? We don't have CT scans like in the adult population. How can I measure the degree of atelectasis in my babies? Well, some have used the chest X-ray to monitor lung volume. Looking at the chest X-ray, determining on aeration, if you have the optimal lung volume, counting the ribs until you reach the diaphragm level, maybe 8 to 9 would be ideal. So this is a study done by Ulrich Thome from Germany, where they actually looked at how precise can you actually assess lung volume with chest X-rays. So what they did, on the x-axis, they measured the lung volume with the chest X-ray, and on the y-axis, they measured the same lung volume by a tracer gas washout technique. And you can see in the triangles here are the babies that were recruited in a high frequency ventilation. And as you can see here, there's actually not a good correlation between what you measure with the gold standard tracer gas washout technique and the chest X-ray. So chest X-rays are probably not a real good tool to determine if you've reached the optimal lung volume. It's also a bit difficult because it's not an online available tool. You make an X-ray, but something can happen 30 minutes later, and you need to do another X-ray to see if this will impact lung volume. And this is not very practical. So for this reason, most of us are using oxygenation as an indirect tool to monitor lung volume and atelectasis. And I'll try to explain this here in this slide. Let's assume this is one alveolus collapsed. Here you have the capillary running by, coming from the right side of the heart, moving through the lung to the left side of the heart. As there is no fresh air in the collapsed alveolus, no oxygen, there will be actually no exchange at the alveolar capillary unit. And this means that hypoxic blood will actually flow by and remain hypoxic when it goes to the left side of the heart. This is what we call right or left shunt. Now we can increase the pressure, and at a certain point, the alveolus will pop open. And this is quantal behavior. So it's not slowly going opening up, but it's collapsed. And when it opens, there's a massive influx of volume in the alveolus. At that time, oxygen will actually enter the alveolus. You will have a nice exchange of oxygen with the blood. And here you will have nice oxygenation of the blood that's reaching this alveolus. This is the optimal VQ match. Going from a collapsed state to an open state is what we would call recruitment. We can increase the pressure even more. The volume will certainly increase, but because the VQ match will remain stable, there's probably not much influence on oxygenation. We can increase the pressure even more, then we get over distension, which means that the volume increases and actually compresses the capillary running by this alveolus. And this is actually the opposite of right to left shunt. This is alveolar dead space, and it will mainly give you a rise in CO2. So this is one alveolus. We know that there are many alveoli or saculi in the lung, all with a different degree of severity of disease, all with a different opening pressure. So if we add up all these alveoli or saculi as the total lung volume and start with a low mean airway pressure on the x-axis with lung volume on the y-axis, we increase the pressure. Initially, nothing happens, but at a certain point in time, the pressure is high enough to open up some of the collapsed alveoli. You will see a steep part where you have a rapid increase in volume of recruitment and distension of alveoli. And as you increase your pressure even more, at a certain point, the lung will be fully recruited and there's no gain anymore by increasing pressure in terms of lung volume. If we would look at the shunt fraction, so the percentage of blood entering the lungs that will run through collapsed units, with 100% being the max, you will see that if you are at the beginning of lung recruitment, a lot of atelectasis will be present, you will need 100% of oxygen to actually get some normal SpO2s. And as you increase the pressure, as soon as you start to recruit alveoli, the shunt fraction will go down and down once it reaches roughly about 10%, which is normal also in adults. And if this was the only problem in the baby atelectasis, you would be able to ventilate this baby with room air while still having normal oxygenation. One of the key things you need to remember with lung recruitment is the law of Laplace. And the law of Laplace states that the pressure you need to open up or keep an alveolus open is 2 times the surface tension divided by the radius. So just to refresh your memory, the surface tension is the force from the wall to the center. So the higher the surface tension, the more pressure you need to counteract this and to open up the alveolus. The interesting part here is the radius, because the radius is here below the equation, which means that an increase in radius will give you a decrease in pressure. So, in other words, if you have a collapsed alveolus, the pressure you need because of this small radius will be high to open it up. But as soon as it opens up and the radius increases, the pressure to stabilize the open alveolus will be much lower. Which means that once you've worked up this inflation limb of the pressure volume relationship and have recruited the lung and then start going down stepwise with the pressure, initially you will not lose that much lung volume because of the law of Laplace, because the radius is increased and you can maintain the lung volume with a lower pressure. But at a certain point, when your pressure is too low, the thickest alveoli or saculi will start to collapse. If you look at the shunt fraction, it will remain stable during the initial decrease in pressure. But as soon as the alveoli start to collapse, your shunt fraction will increase and your oxygenation will deteriorate. To make this more visual, here we have a piglet lung, surfactant deficient. We start to increase the pressure. Slowly, the lung opens up, and at the end of recruitment, we have a fully recruited piglet lung. Then we will go down with identical pressures. And then you can see the effect of hysteresis as you are maintaining the lung volume at the same pressure, quite differently if you're on the deflation limb or the inflation limb. Here is where we want to ventilate our babies. So these are all piglet lungs and theoretical arguments. What about real babies? Do babies with RDS, for instance, have lung hysteresis that we can use when we recruit the lung? And we tried to answer this question some years ago in 15 babies with RDS below a kilo. We had the opportunity to measure lung aeration with a tool called electrical impedance tomography, which lets you quantify aeration in the lung. And by doing so, we were able to go up with the pressure and down with the pressure in these babies. And we clearly showed that babies with RDS before surfactant treatment have an inflation and a deflation limb that are not running across the same area. So there is a difference between the volumes depending at the same pressure, depending if you're on the inflation or deflation limb, which we call hysteresis. So if we use high frequency in our unit, we actually have this strategy. So we have the mean area pressure on the y-axis, time on the x-axis. We start at a relatively low mean area pressure, making it very simple. If you don't have good oxygenation, there's only one way to go, and that's up. Instead of flying in somewhere in between at a high mean area pressure, where you're never sure if things are not running as you expected, am I in overdistension or am I still too low with my pressure and having atelectasis? So starting low, 8-9 centimeters of water mean area pressure, we stepwise start to increase the pressure. And as we increase the pressure, we would expect lungs to open up, atelectasis to be reversed, shunt fraction to go down, oxygenation to improve, allowing us to reduce our FiO2. Once we've reached a target FiO2, defining optimal lung volume, we stop and we call this the opening pressure. Now it's really important that you don't leave the baby there and go for coffee. No, you want to take advantage of the hysteresis. So you're going to walk down the deflation limb, reducing the pressure step by step while maintaining the FiO2 stable. And you watch the SpO2. And as soon as the SpO2 starts to deteriorate, then you know you were too low with your pressure decrease. And now you've reached the closing pressure. Once we have closed some of the alveoli, we need to reopen the lung with going up in one move to the opening pressure, and then we will reduce the pressure to 2 centimeters below the closing pressure to optimize and stabilize the lung volume with the lowest possible pressure. This way, you actually individualize the pressures that you apply to the lung, because you will have babies with modest RDS or severe RDS, and these babies do not need the same opening pressures and the optimal pressures. Individualizing is the best way to avoid adverse effects during high frequency ventilation. Now, what would be the ideal FiO2 to define the open lung? Well, I told you that theoretically, if it's only atelectasis, 0.21 room air would be the target if you want to fully recruit the lung. But of course, then you have this risk of maybe overdistension in healthy lung units. So we have decided in our unit, if a baby has simple RDS, there's no persistent pulmonary hypertension present, then we would usually target an FiO2 below 0.3, and if everything goes well, even below 0.25. However, if you're using this in a 2-week-old baby with already developing BPD, with a heterogeneous lung disease, you will probably not reach the 0.3 FiO2 if you recruit the lung, and we will probably aim for an FiO2 below 0.24. If you do have PPHN, then it's a completely different patient, because now you will have also extra pulmonary right to left shunt through the open foramen ovale or the patent ductus arteriosus. And this complicates oxygenation as a tool to measure lung volume. In these babies, especially the one with meconium aspiration syndrome, we would leave the FiO2 at 1 and try to measure the best PaO2 by recruiting the lung. It's also important to realize that sometimes you don't reach the target you want. So if you don't reach 0.3 in an RDS baby, then you just leave it at 0.35. This is the best you can do, and you go from there. What about the pressure steps? Usually we take pressure steps in babies with fresh RDS of 2 centimeters of water, and we wait at least 2 to 3 minutes to see what the effect of the increase or the decrease is on oxygenation. If oxygenation is still changing after 2 to 3 minutes, you wait as long as needed before you see stabilization. In babies with developing BPD, heterogeneous lung disease, it will take a longer time before you see the effect of a pressure step on lung volume and thus oxygenation. It could take 10 to 15 minutes after a pressure step before you can see the full effect. So in these babies, we will take longer time between the steps, and to make it practical, we take slightly bigger steps because you can't do a recruitment procedure for 3-4 hours for babies. So 3 centimeters of water, waiting at least 10 to 15 minutes to see the full effect in these babies is really important. In some babies with very severe meconium aspiration, you will need very high pressures to actually recruit the most sickest part of the lung. We would go up in these babies stepwise up to 20 centimeters of water, and then sometimes use sustained inflation. So moving the pressure up to 25 for 20 or 30 seconds, and then go back in one step to 20. Move the pressure again up to 30 centimeters of water, leave it there for 30 seconds, and move back to 20. This way you can actually recruit some lung tissue while avoiding high pressures for a long time. So, getting more practical, what kind of pressures are we talking about? This is a study we did in RDS babies before surfactant treatment, where we looked at the pressures and the FiO2s that we reached. There were 100 babies. What you see here are the different stages of lung recruitment: start, open, closed, and optimal. In blue, you will see the actual pressures, and in yellow, the FiO2. You can see we start with a relatively low mean airway pressure, where we need a lot of oxygen, 70%, because there's a lot of atelectasis. We stepwise go up, and in these babies, before surfactant treatment, the mean opening pressure was 21. And you can see we were very successful in this cohort, where we reduced the median FiO2 to 2.4. Closing pressure was 12, and the optimal pressure was 14. As you can imagine, FiO2s remain stable, and go from 21 to 14 is the actual hysteresis that I talked about. What about the other settings? Frequency, usually between 8 and 15, depending a bit on the underlying lung disease, but also the size of the baby. The amplitude that we set depends on the ventilator, but we aim for a very slight wiggle. And then if you have this available on your ventilator, you can actually look at the tidal volume, targeting usually 1.5 to 2 mL per kilo to start. What's really important in my unit is we want to see spontaneous breathing, because if the baby is breathing spontaneously, then you are pretty sure that you will not end up in the low CO2s. The IE ratio usually 1 to 2, but in some cases 1 to 1, and in some ventilators you actually can't change this. So what about problems, practical problems? Well, we know that head positioning is important in terms of CO2 clearance. In some of the smallest babies, below 750 grams, you can see sometimes that if the tube is close to the trachea wall, you will like a dampening of the amplitude. This will give you a rise in the CO2. So this is a You need to reposition the baby and look at your tidal volume. We know that overdistension is a danger if you use high frequency. It's not so much a danger if you individualize with the strategy that I showed you in the previous slides. If you want to have markers or indicators of overdistension, high CO2 is the first one, and low blood pressure, which is a very serious one, is also an important factor, an indicator for overdistension. Hypocapnia, we've learned from many of the trials that have been done, hypocapnia is a real danger in high frequency ventilation. So you need to monitor your CO2, which means that all our babies are on transcutaneous CO2 in the unit. And then in the morning and the evening, we take a blood sample, see what the association is between the transcutaneous CO2 and the blood CO2. Like I mentioned, we want to have spontaneous breathing in our babies. Otherwise, we will just blindly reduce the amplitude until the baby is spontaneously breathing. Now, one of the options that is on most of the more modern ventilators, the hybrid ventilators, is volume guarantee. And it is a solution in this risk of hypocapnia. Basically, it works very similar to what we've known from conventional ventilation modes. So the clinician actually sets the oscillatory tidal volume. It's really important to realize this. And the ventilator adjusts the pressure amplitude automatically to target and stabilize this set oscillatory tidal volume. And the idea is that it avoids the swings in tidal volume and, more importantly, the swings in CO2. There is some evidence to support this. This is a study done where they actually randomized babies to high frequency ventilation with and without volume guarantee. And for instance, they measured the tidal volume, the oscillatory tidal volume, and you can clearly see that the variation in the tidal volume in the extremes are much bigger in babies that were just on high frequency ventilation compared to the ones that actually had high frequency ventilation with volume guarantee. The only caution that we need to take into account is that there is no magic number in terms of tidal volume. You can't say a 1.5 or 2 mL per kilo oscillatory tidal volume will work for every baby. This is a very nice study done in the UK where they actually looked in a lot of babies that were on oscillation with volume guarantee on what is the association between the oscillatory tidal volume that's been set by the clinician and also measured and the actual CO2 in kilopascal. And although there is a modest correlation between these two parameters, if you just look at this baby, this is the tidal volume of, in all cases, of about 3.2 to 3.3 mL per kilo. And because this is the same color and the same marker, this is all the same infant. And if you look at the corresponding CO2 at this tidal volume in the same baby, you can see it ranges from 4 to almost 9 kilopascal, meaning that there is a difference in the actual tidal volume depending on many factors. For instance, overdistension, yes or no. So there is no stable correlation probably between the tidal volume that you set and the CO2 that you will get in the blood gas. So we need to monitor this as much as possible. Another important thing you need to remember is as soon as you activate volume guarantee, the relationship between frequency and CO2 removal will switch again with high frequency. So I mentioned to you that normally with high frequency change will give you the opposite effect in terms of CO2 clearance as you would have with conventional ventilation. But if you switch on volume guarantee, it will actually go back to the same relationship as with conventional ventilation. And this is because the tidal volume changes that are induced by frequency changes are corrected automatically by the ventilator. So remember this. So briefly, what about non-recruitable lung disease? Actually, it's the same strategy, except that you do not recruit the lung because you avoid any overdistension and you are probably not having that much collapse of alveoli. So overdistension is the key thing. You want to use high frequency to induce normocapnia with low tidal volumes, thereby avoiding overdistension and air leaks. You often have hypoxia in these babies, but it's mainly due to PPHN. So we would use chest X-rays more often in these babies to actually assess the aeration of the lung because oxygenation is mostly unreliable. And we would avoid any recruitment in these babies. So basically in practice, it means that we will very, very reluctant to go with mean pressures more than 15 centimeters of water. So I mentioned this briefly. We have a lot of new ventilators out there on the market. And the question is, are they all equal? Yes, most of them actually are able to provide conventional ventilation modalities and high frequency. I mentioned that many of them now have some form of active expiration. They've improved considerably in the power, and they have also improved monitoring. So different, yes or no? Well, I think they are. And I think you need to be aware of this as a clinician. So these are a couple of papers that have looked at how they actually differ, these different kind of high frequency ventilators. So this is one example where you actually look at the set delta pressure and the actual pressure that is induced and measured at the airway opening. So ideally, you would like to get what you actually set as a clinician. And if you look at some of these ventilators, you can see it's a very nice straight line where you actually have a good correlation between the set delta pressure and what is measured in the patient. But there are also ventilators that actually have a different relationship, sometimes linear in the lower parts, but more horizontal in the higher settings of the delta pressure. So it doesn't mean that you can't use these ventilators to apply high frequency ventilation, but it means you need to be aware of these typical characteristics of the ventilators. And another example is the tidal volume, the oscillatory tidal volume that is applied by these ventilators, the power they have. It also depends and differs in the ventilators that you use. These are different conditions. Term lung disease or preterm lung disease is an in vitro model using different frequencies. And if you look at the tidal volume that is delivered in these babies, especially in the term babies at higher frequency, you can see that there is a problem in terms of the actual tidal volume that is reached. So again, you need to be aware of these differences, and you need to make sure that you have ways around this when you use these ventilators in your babies when using high frequency ventilators. So to summarize, I hope you will agree with me that if you are using high frequency ventilation in your unit, first of all, you need to understand the basic principle of how high frequency works. You need to understand the physiology of the lung. You need to understand that high frequency can be used in different underlying pathologies, but does require for you to actually have different strategies. Applying a recruitment strategy in a baby with lung hyperplasia will get you in a lot of problems and trouble by using this strategy. I hope I convinced you that you need an individual and dynamic approach. And although the ventilators that we use nowadays are improved, have more performance, they still differ on some of the key aspects of high frequency ventilation. You can use them in your patients, but you have to know these characteristics of your ventilator. Thank you very much.
Thank you very much, Professor Van Kaam, for that fantastic presentation. We do have some questions in the Q&A that I'll share with you. First of all, how do you manage babies upon circuit reconnection if you have to break the circuit/disconnect?
Yeah, that's a very good question, because as soon as you disconnect the baby to ambient air, then you actually will fall off your deflation limb back to your inflation limb. So you will lose lung volume. So basically what you will see when you reconnect the baby, there will be some regaining of lung volume because now you apply pressure, but you will see that your FiO2 will probably increase because there's remaining atelectasis that is not resolved by reconnecting and using the pressure that you used before the reconnection. And this means that you will have to reopen the lung and go back again to the pressure that you had before reconnecting to get the full lung volume back.
Thank you. The next question we have is it useful to use dCO2 and tidal volume during lung recruitment to determine the optimal mean airway pressure?
Yeah, that's a very good question. I didn't have time to go into the details on this, but as I mentioned, if you look at the inflation limb, there's a flat part in the beginning, a steep part in the middle, and a flat part again at the top when you reach total lung capacity. It means that compliance will change as you move from a low volume to sort of a bit of overdistension. And because of these changes, the tidal volume will be relatively low at the same mean area pressure, delta pressure in the beginning. It will increase when you go into the steep part of the inflation limb, where you have the optimal compliance, and it will decrease again the tidal volume if you are starting to move up the flat part at the upper part of the inflation limb. So what I do in my unit is I look at the tidal volume. I can see when moving into the straight part, as oxygenation improves and my tidal volume improves, I'm on the right track of recruiting this lung. And then once I see tidal volume dropping off a little bit, usually at the time that I'm approaching my target FiO2, then these two factors actually tell me I'm almost there. There will be a little bit of overdistension to recruit the sickest ones at the final part of lung recruitment, but then you need to back down with your pressure, and you will see that your tidal volume will improve again once you do that and go on to the deflation limb of the pressure volume relationship.
Thank you. The next question is, do you use lung ultrasound to monitor recruitment?
Yeah, very good question. I know there's a lot of increasing evidence that lung ultrasound can help us to determine the condition of the lung. I also know that there is some studies have been published recently where they actually tried to assess lung aeration by using lung ultrasound. And there was a correlation between what you can measure on the ultrasound in terms of lung recruitment. For me, it could be an additional tool, not replacing, but additional tool to get more information on lung aeration. The only thing is, it's not an online tool. So you need to put on the probe every time you want to have a look at this, unless there is a way to actually, stick the probe on a baby and do this as a sort of continuous monitoring tool. So I think it's a promising tool. It's an add-on tool giving us more information, but we should not make the mistake as using it as the only tool to assess lung volume.
Thank you. The next question is spontaneous ventilation good for preventing alveolar atelectasis or just for clearance of CO2 during HFV?
Again, a really good question. First of all, it will help in the CO2 clearance. So I think it's really important to monitor spontaneous breathing also in the babies on HFO. Especially if you want to assess your transcutaneous CO2. If your transcutaneous CO2 is high, the baby is not breathing, then it's probably not an accurate reading. If the CO2 is low, the baby's breathing, then the baby is more in control of the CO2 than you are as a clinician with your high frequency ventilation. So I think it's a really informative tool. We want to see spontaneous breathing in our babies. Like I mentioned, there's no synchronization necessary. So I would think that it's for CO2 clearance an ideal tool. Now the question is, can a baby by inhaling recruit alveoli? I think this is possible because when we see babies that are suctioned with a closed system, and we measure this also with electron penis tomography, we see a drop in aeration. Then when we stop suctioning, it actually goes up. And my theory is that some of the babies, by breathing and sighing a little bit, they actually recruit some of the lung volume, and they were stabilized by the mean pressure that you apply with high frequency. Although the evidence to support this idea is very limited.
Thank you. What are your thoughts on closed loop oxygen control with HFOV?
Also very interesting. Of course, it will help you as a clinician that you don't need to touch the FiO2 button when you are recruiting the lung. So as you are recruiting the lung and the SpO2 increases once you've recruited alveoli and the VQ match improves, then the ventilator actually weans down your FiO2. It will make things even easier for you as a clinician at the bedside recruiting the lung. In the end, it is still the FiO2 that is guiding you in your lung recruitment and your strategy.
Thank you. The next question is, why in volume guarantee with HFOV do you set the amplitude and not pressure?
I'm not sure I'm understanding this question.
No worries, we can move on to the next question. What is your opinion on optimal frequency for different lung pathologies? Yeah,
that's a really good question. And I know there's a lot of theories in terms of the corner frequency in underlying lung disease, which is different, the resonance frequency. I think there is a difference in terms of going sometimes to the lower frequencies in babies with air leaks, emphysema, and maybe going to higher frequencies in the babies with more constrictive lung disease with RDS and these kinds of diseases. For us in clinical practice, we usually start at 10 Hertz and then define on the underlying lung disease, CO2 clearance, together with the amplitude that we set. If we move more to the higher frequencies, for instance, tiny 500-gram baby is more likely to be on 15 Hertz because you want to have, when we change the amplitude, the tidal volume change should be very minimal, so we can actually tweak the CO2 in much detail. In bigger babies where meconium aspiration, sometimes we go down to 8 because we need these higher tidal volumes and this lower frequency to get the CO2 out. I think we need a lot of more research on the clinical implications of moving from two different frequencies, although there's a lot of theoretical background on why this could differ depending on the underlying lung disease.
Thank you. When do you use an IE ratio of 1:1 or 1:2?
So in our unit, we only use 1:2. I'm not saying that you can't use 1:1. Changing the IE ratio would also change how pressure is transmitted from the airway opening to the lower part of the lung. There have been some older studies suggesting that there are conditions where a 1-to-1 ratio can lead to sort of an air trapping in at least animal models. I'm not sure if this is the case also in real babies. So to move away from any risk of air trapping, we decided in our unit to use the 1-to-2 ratio instead of the 1-to-1. But I know there are also units that actually use the 1-to-1 and actually see not that much problems in their babies.
Thank you. How can we manage a patient with unilateral collapse? Is there possible of air leak in the opposite lung?
So if there's a baby with a collapse of a full lung, left or right, with some overdistension on the right lung, then of course, by changing the position of the baby, you can actually try to open up the collapsed one. I think that the risk is that if you start conventionally ventilating this baby with normal tidal volumes, then like I mentioned, the 6 ml or the 5 mLs that you actually set at the Y piece with your volume guarantee conventional will be 10 or 12 mLs on the lung that's open and have the risk of air leaks. Again, in these babies, high frequency ventilation could be one of the solutions to actually get the CO2 out while waiting for the lung to reopen by moving the baby in the lateral position.
Thank you. Do you administer surfactant at intubation or at any other time?
So nowadays, the majority of babies will receive LISA or MIST, depending on what you use, so non-invasive surfactant treatments. Babies that do not qualify for this, so babies with a low respiratory drive, these babies are still intubated. Then we first recruit the lung in these babies, and then we use surfactants. There's been a big debate, why not give surfactant first and then recruit the lung, because then you will need the lower pressures. For us, getting surfactant in there and starting lung recruitment, then you have two factors: surfactant changing the surface tension, recruitment changing the radius. It gets complicated in this way. Second, there's been a trial done in Italy where they actually randomized babies to different strategies, and this trial showed that you have better results if you first recruit the lung and then you give your surfactant instead of first giving surfactant.
Thank you. And we have time for one final question. Do you have a preference between closed suctioning or open suctioning, followed by a re-recruitment maneuver?
Yes. So all the babies in our unit we use closed suctioning. You will still get, by suctioning, a drop in lung volume. This is unavoidable, but it's much less than if you disconnect the baby and do an open suctioning procedure. And like I mentioned, once we did suctioning, we leave the baby for, let's say, 10 minutes at the same pressure that the baby was on before suctioning, and then wait and see if oxygenation improves. And in a lot of babies, it actually improves, and you will get back to the original lung volume that you had before suctioning. If your baby is not fully recruited after 10 minutes, then we would increase the pressure at that point in time following the suction procedure to regain the lung volume to where we were before suction.
Thank you. That's all the time we have for this afternoon. Thank you so much, Professor Van Kaam, for your excellent presentation. And thank you to all of our attendees. And I hope you have a great rest of your day.
Thank you.